So I approach this talk very cautiously. I would like to just give you a little bit of my background. I did my first echocardiogram in 1965. We were the group that invented the phased array and three-dimensional echo. Along the way, defined some of the standards for color flow and a variety of things like that. And here we are at a time when we're able to do all these magical things with catheters. And here we are in a meeting where we're describing more and more and more how we're lowering the thresholds so to be able to do these procedures in lower and lower risk patients. I do look at one study as an example because when we talk about mitral valve disease, we have to look at echo particularly, how good are we? And how much do you as an interventionalist or as a general cardiologist or even an echo person, how much do you know about what we do? I do want to point out that when you look at this, the COAP trial, which was recently, I'd say, published, that said we should be doing these things or could do them safely in patients with heart failure, and Mitraclip being one of those things. And we just heard a talk where it was mentioned that we have something like 600 centers in the United States able to do these interventional things. Well, you know, and I know, that this is introducing more people with less experience. And the people talking to you today are all highly experienced individuals. And when you think about echocardiography, it's just available everywhere. Many of you think that when you turn the echo machine on, it's just going to operate in some very easy way. Just hit the color button and the color is going to show up and you have mild, moderate, or severe mitral insufficiency. Well, I look at this trial and I see 78 sites. Half the patients had 3+, the other half had 4+ MR, symptoms despite and medical treatment, and half of them went to devices and half of them were controls. And you look at the success of it, and it's quite remarkable. In the device group, heart failure or hospitalizations were down, the freedom from complications was up. I mean, it was amazing. And when you look at all-cause mortality, obviously the device group did better. Now, a lot of this mitral stuff is based upon echo and based upon that finger that touches the button and says mild, moderate, or severe regurgitation, not only in qualifying patients, but in following them. And from my perspective, there are problems. And the problems exist that we don't all understand how echo works. And whoever said that echo was so reliable anyway? And when you look at these groups and you say, oh, there was a core lab or something like that, we have to look at the fact of what did they look at and how much did they understand. Well, I'm not going to talk much about structural MR because I think you all know that echo can define with reasonable ease. Is there prolapse? Are there other things that could be managed in a different way? I'm talking more about the, quote, functional patients. Can we as a group collectively get MR right? Now already you understand, and I'm sure you can accept in me speaking, that I've got a lot of skepticism about a lot of things. Now when I was much younger, I had a lot of skepticism, and I'll show you a picture of me back then. A lot of people said I had a bad attitude. Now, this is back when I had hair and a variety of things like that. But I do want to announce that over these years, I want to remarkably say I've changed. I also want to point out that I have this attitude and skepticism, and I've passed it along in my genes. And so I want to show you my granddaughter. She's Lily, that's her name. This is a picture of her a few years ago. She's got the same attitudes and skepticism. I'm going to be talking about how to use an echo machine, and hopefully you all will be able to follow me with some of the things. And these are published, and they're not published widely, but they do exist in these two publications, the most recent being a book that Petros and I got together about. And we've got 3 rules of echocardiography in our laboratory. First rule, if you don't point at it, you can't see it. Now this is quite profound, actually. The second rule is if you can't see it, you can't do the measurement or make the diagnosis. And all of you know that echo's got some limitations in image quality. And the third of the 3 rules is what we're going to be talking about today. And that is, many of you believe in this room that when you look at an echocardiogram, you're looking at the heart. And when you look at flow, you're actually looking at flow. And I would like to say that it's not. You're looking at an electronic representation of ultrasound waves just going out there, being reflected back, subject to all the problems that can exist. And in our lab, and it's in a bronze plaque outside of our laboratory, it's not the heart, stupid. It's an electronic image of the heart, and we've got to understand how that's done. We also have the fourth of the 3 rules, and that is talk to each other, and that's what we're here about today. I'm going to use the examples of how good we are in evaluating mitral regurgitation and the lessons from the fen-phen business. Now, this is all the diet drug stuff that existed about 10 years ago. And this paper was published by Heidi Connolly from Mayo, and it was published in August of '97. And what she said was, well, these drugs can affect thickened valves, and in fact create the mitral regurgitation, and in 1 month these drugs were withdrawn. Now this was remarkable, and this led to incredible amount of problems, but basic to it all was whether we could evaluate mitral regurgitation well, and who, by the way, would ever doubt echo, because we had been doing this for years and years and years. Well, when you do some Google searches, you see things like the fen-phen bomb, and all the fen-phen acquisitions to send your patients here. There was even fen-phen Barbie, who was remarkable. I'm not quite sure what that meant. But what was anticipated from this entire litigation and all the studies that were done was that there would be, of 18 million prescriptions out there, there would be approximately 1,000 patients that would be affected. And look at what happened. There were individual suits of 70,000 people sued the drug manufacturer. Some of them went into the trust. This is another 70,000 people went into the trust. And of the trust, which was funded by Wyeth, that was $6 billion. If you had moderate mitral regurgitation and took the drugs for 6 weeks, you automatically got $250,000. No questions asked. Now, how much was this liability on 70,000 patients at $250,000 a patient? Let's just put this in context. This is a Nimitz class aircraft carrier, roughly at the cost of $5 billion. The liability alone in the trust was the equivalent of 14 aircraft carriers. And when you look today at the money involved in all these devices going into patients, let's just get a comparable example of that, because there's a lot of motivations to push this. One of the motivations, and certainly Abbott's, has been published as their market value of these Mitraclip, so it would be probably $8 billion. That's only 1.6 aircraft carriers. Let's look then at the fen-phen business. We were able to evaluate, and I was called upon by the federal courts to look at these, to be able to evoke were any of these claims really legitimate. Now, mind you, we looked at 1,000 claimants. The drug for 6 weeks, moderate to severe AR or MR, most of them were mitral. And they all underwent an echocardiogram in their local institution, and they all went to an audit committee that was considered to be a core valve. They were all approved, all 1,000 of them. Nobody could believe that actually 1,000 of these could exist. all were awarded $250,000, but they didn't get the $250,000 yet. Therefore, the federal court ordered that all the echocardiograms be examined. You look at echoes like this, I know you could tell on the left it's mild, on the right it's moderate MR, but let's look at how this large group of people, because we went back and audited them all again, essentially checking the core lab. And here's what it was. Of the nearly 1,000, 30% of them had legitimate mitral regurgitation. The remainder of them did not. Now that's remarkable to me, and I was shocked. And when you look at one of the claimed mitral regurgitations, I think you'd say that's legitimate. Let me show you an example of what was submitted and approved and awarded $250,000. Look at that echocardiogram. Done by board-certified people, gone through the core lab, and approved. Now, to me, this is remarkable. Let's look at the reasons why. Particularly, you folks, the surgeons and other people involved that are not echo people, to look at what you need to look at in the echo. What was involved here? As the mitral valve closes, there is blood trapped between the two leaflets. And when they close, this is called backflow. It's a sudden burst of regurgitation that comes back. Now, you can determine that by looking at the echocardiogram here from the apical four-chamber view. You can see the red, the blue in the left ventricle. That means the ventricle is in isovolumic contraction. In fact, the mitral valve's closing, sending this blood back, this sudden burst. Now we've outlined all the frames of systole, and you can see in S2 the sudden burst. But the rest of systole didn't exist. Now, this is another thing. Think about this. When you go to fill your bathtub and you turn the water on, you get a big jet. But in 5 seconds, if you turned it off, you didn't fill the bathtub. So we've got to look at jet durations to understand what the load is on the heart. This is not a part of any of these color flow evaluations done on these trials. Let's look at this. Here's mitral regurgitation throughout systole. It's not a lot, but it's throughout systole. Here's serial systolic frames in more severe mitral regurgitation. So time is of importance. Many of these individuals in fen-phen were called severe because the criteria was rather simple, not necessarily good. It was 20% jet area to the size of the left atrium. That's what qualified. Well, you can tell some of this by spectral Doppler. Here on the left, you see an early jet, the density of the flow. But effect of color gain is, I'm sorry, we skipped backwards. Effective color gain. There's an easy way to create mitral regurgitation that's severe by echo. Just go up in the color gain, dial a jet. This was a serious problem. And these were all established laboratories, all certified labs, all board certified people. And if you look at what color flow could do, here's a smaller jet. If the image gain goes up, the color argues with the black and white as to what it's going to display with pixels. Just make sure that the image gain's not up too high. If the color gain goes up, the jet gets bigger. Another example, and you can read this on some of the controls. There's color gain of 12, in the middle 17, on the right is 24. Look at the size of the jet increase. How do you standardize the color gain in your labs? Do you even look at it when you're evaluating a patient to do an interventional procedure on? And I would bet your eyes are not tuned to this. Here's some crazy stuff in one of these submitted ones. Look at this. It's just a mess of sparkles, of things. This was qualified as moderate mitral regurgitation. Now, image gain, the 2D part of it is significant too, because this argues with the color pixels back and forth. And there's a number of settings in machines, tissue priority, the color priority, that can determine what's going to occupy a pixel. And here's where image gain goes up and sort of cancels the color flow. And here's another big one, which I'm sure you don't check, and that is the Nyquist. This is the number of pulses being sent out. Look at on the left, the baseline, and if you decrease this Nyquist, this limit, which on the right is 49, on the left is 70 something, you can see the jet appear. Check your Nyquists. And interventionalists, please look at your Nyquist. We have standardized certain things, but it's roughly about 60 from the chest wall. But these jets can be made larger. Here the PRF can change. If the PRF, which changes the Nyquist, changes by 25%, you triple the size of the jet. We're dealing with dial-a-jet here. So please understand how the machines work. Many of you are in university hospitals. The quality is generally good. But with 600 of these places coming out there, sticking these devices in the USA, I'll bet you we're dealing with the exact same people that submitted the fen-phen claims. Effective frame rate. If the frame rate is high enough, especially with a moving jet, you'll be able to follow it. Look on the left, there are two frames. You see a small jet move. On the right is the same individual, but at a lower frame rate, so it occupies a bigger space. That's simply a bad temporal resolution. Tons of things. Persistence. I'll bet you didn't know in your echo labs that your machines are defaulted to persistence. That means that one frame is added on top of another frame, added on top of another frame, which is going to make the jets look bigger. I encourage you to make sure persistence is turned off in all your echo machines. I see no reason for it in any cardiac exam. So in exaggerating a jet, you can see the same patient on the left with all the manipulations. You can see what happens on the right. All of a sudden, we make them moderate MR. The same thing, we can exaggerate. Look at what was measured in some of these people. They were measuring the size of the jet. They measured a hemisphere. You want to see another crazy one? Look at this one. I have no idea what they were measuring. We could duplicate many of these recipes. When you look at this carefully, look at the size of the jet constantly increasing. We could see it happening in front of us with them adjusting the machine. So there's a lot of things. The patterns of backflow were measured. High color gains were all over the place. Look at the sparkles. We were able to develop some standards, and they do exist, in comparing them to established echo in university labs. More likely, less likely. Look at the variation in the quality of echocardiograms in terms of proper system use. Just let me conclude by the following thing. I hope I have put some caution in you, and that's my role here. Can we do it right? I should add, though, that all of this was published in Forbes magazine, and it was under the title Doctors, then Lawyers, and Thieves. Now, you could say that this was a motivation for either mass fraud, which is hard for me to believe, or it reflected the status of everyday echocardiography, and I believe that, is we don't have controls over it. I should also add that I was a part of the Federal Department of Justice and the federal court in putting some of these people in jail for fraud. I would expect, as we approach through Medicare, this experience is going to duplicate itself. And in fact, there will be fraudulent claims rendered, and they will be examined in somewhat the same way. Let's finish by looking at a patient. We'll call her Jane Doe, 57-year-old female. She's heavy, 250 pounds. So no history of shortness of breath, no murmurs. She just went in for her fen-phen echo. 6-4 on June the 4th. Here's her echocardiogram. She was called moderate MR. Now, if you look at the controls, Nyquist was shifted. Lots of things were changed to make the MR look bigger. In 2 months, the report came out. She visits a cardiologist 2 days afterwards. 2 days after that, she gets a stress echo. And then in 10 days, she gets a transesophageal echo, and she gets a cardiac catheterization. Here's her transesophageal echo. What happened to the MR? Where did that go? Not much, is it? I don't know. I don't think any of you surgeons would operate on this. Let's look at her angiograms, because she had a cath too. I don't think you can argue here for severe MR. And the LAO, I don't think you can argue again for severe well, it's not playing. Well, look at what happens on that day. This is what she gets. She gets a St. Jude valve. We're going to be seeing these things, and I'm just here to caution you to be careful about how we use echo, and if we're going to do it right, let's do it right. So an old slide. We got all these machines, all of them behave differently. We got different operators. We've got different standards in different labs, and a lot of us don't look at the quality or the controls of how these jets were generated. So in this old slide, just be very careful. And in conclusion, I'd just like to say the responsibility, so for doing it right, falls to you, which means it falls to me too. I appreciate all your attention. Thank you very much.
Thank you very much, Professor Kisslo, for your very important, experienced presentation. I would like to caution here saying that no doubt, everywhere around the world, there is overuse, misuse, also underuse of these devices. And unfortunately, in the most rich countries, overuse is quite a common phenomenon. Any questions?
I think, Joe, another issue is the guidelines. And one of the differences between the co-opt and the French HF study is that the guidelines, they were using different guidelines in assessing severity of mitral regurgitation, because the French guidelines, the French study used the old guidelines with 40 mils severity, and the American guidelines lowered, used the updated guidelines.
Yeah, and I'm not so sure the guidelines are written by people that know what they're doing.
Well, often the majority are not.
Yeah. And we have another problem with echo. Now that we're training people to do imaging, which means they spend time in echo, CT, MRI, I firmly believe we can hardly get them trained in echo and hardly get them trained in MRI. They're just doers of things. When you present this information and give it to people and talk to even experienced individuals, many people don't understand that if you want to make a big jet, just go up a little bit in the gain, decrease the Nyquist, and all of a sudden you qualify. So I just say we got a lot of work to do. But you're right, Petros, the guidelines are quite variable.
Anybody else?